Okay, good evening, everyone. So hopefully you all can hear me and hopefully the audio is working fine. If you can hear me, that's a great sign. That means you'll be able to hear our speaker for the day. For the evening rather. So good evening, welcome, welcome. Want to extend a warm UD welcome to Dr. Lana Bamiro from Tenet Healthcare based out of San Antonio, Texas. So he is a public health scientist, respiratory therapist, and author, amongst many other hats. He has graciously taken some time out of his busy schedule to share with us a little bit about his own career trajectory. He's worked both as a healthcare professional and also a healthcare administrator and public health scientist. He will be discussing the role of multidisciplinary healthcare management. He'll also share perspectives on, what it's like to take care of patients from admission to discharge. And also we will have plenty of time for some Q&A. And we look forward to all of those questions. And again, 2 lucky attendees will receive a Starbucks gift card. So we'll be doing that random prize drawing at the end of Dr. Bamiro's seminar. So be sure to listen to all of the details he'll be sharing. And I'm sure it will be well worth our time for this evening. So again, a warm UD welcome to Dr. Bamiro.
Thank you so much. Can you all hear me just fine? Thank you. Thank you so much, Toby. Thank you to all the students. Thank you, Carla, for also being here. I'm a big fan of education, as many of y'all are. And when you think of the decision that some of you might make at some point to pursue higher education at a graduate level and even up to the doctoral level, you got to really love education to go through that. And so I think it's one that you all should consider at some point. I'm going to share my screen as I start to tell you about the multidisciplinary healthcare management. Dr. Toby's done an amazing job, really just giving you all my background, but I just share a little bit more, and the why to that is to kind of just help you see that healthcare is multifaceted, and then we'll break down these words, multidisciplinary healthcare management, somewhere in discussion as I share a little bit about myself. And so, as she's pointing out, I started my career as a respiratory therapist. I was a bedside respiratory therapist, and more than likely, y'all, if you were not as aware of who respiratory therapist was before 2020, you probably got a crash course there, media, call it whatever media outlet you subscribe to, with COVID-19. And so the role of a respiratory therapist is really that clinician that functions to improve breathing for patients in general. And that's just a very soft way of describing that role. But having said that, started my career as a respiratory therapist at the bedside, and had the opportunity to step into leadership. I'll share a little bit more. I went to school at El Centro Community College, and then earned my bachelor's in health administration, respiratory with a minor in health administration. And then I thought I wanted to go to pharmacy school, and so I moved to Oklahoma and went to school at OU, and I took a couple courses and realized it wasn't for me, and had the opportunity to visit with an administrator at the time, and shadowed him, and realized that although I'd already earned my minor in health administration, I really wasn't aware of what it entailed. And so I really liked it, and went back and got an MBA. While I was earning the MBA, I realized that in order to really connect to getting people to move from point A to point B for their health, other than managing the acute state, was certainly a need to be more cognizant around public health, and be more aware of what some might call population health, and we'll talk a little bit more about that. And so I went and earned an MPH soon after that, and then a doctor of public health. And so that's been my trajectory from an education standpoint, and likewise career, respiratory therapist, leadership, and now I function as a service line administrator over 6 hospitals with Tenet Healthcare in San Antonio market, responsible for the neuroscience service line, which entails neurology and neurosurgery and spine and epilepsy and seizures and some of those diagnoses that you might be aware of. But that's my trajectory, and then taking basically all I've said and look at these 3 words: multidisciplinary healthcare management, multidisciplinary healthcare management. If we're to break those words down, multidisciplinary is in essence having individual disciplines collectively work, right? And then healthcare is the industry in which we speak to, is the industry in which we speak of. And then management is basically how you eliminate waste and reduce variation in order to achieve your goal. Moving on, the objective for today. There we go, that went so fast. All right, so a couple of disclosures, I have none, but I am affiliated with these entities, Healthcare Leaders of Tomorrow. It's basically a platform that empowers future healthcare leaders. The American College of Healthcare Executives. I'm a fellow of the American College of Healthcare Executives. As a respiratory therapist, I'm a member of the American Association for Respiratory Care. Also a member of the American Public Health Association. And as Dr. Toby had mentioned, I work for Tenet Healthcare. I do not speak on behalf of any of these entities. Now, the objectives. What I'd like to really do over the time that we have together is to really define what that multidisciplinary healthcare management is. And I kind of gave an overview with the first page, but really just do a deep dive and touch on the different tentacles, if I may, that I believe connect to the definition of a multidisciplinary healthcare management. We'll understand the key players in healthcare management, and then we'll identify a few current trends in multidisciplinary healthcare management. Those are the objectives for today. All right, now I'm hopeful that you would be able to hear this, so I'm going to take a chance with it. If I could get a thumbs up that you could hear it.
Nothing so far in terms of audio.
Let's try that again. I did test that. Forgive me, I am going to do something different. And we'll do it. Of course there will be technical. All right, let's try this differently. Are y'all able to hear the audio?
Not yet.
No, I wasn't either.
Oh, bummer. Let's see if that works. How about now?
Yes.
Hey, you there, pick up the pace. You're falling behind. Come on, let's go. Everyone, pull together. We've got us a rescue on our hands. You there. Here we go.
All right, and you've probably seen that clip before, but the premise I'd want to share is that healthcare management is, in essence, a team sport. It is a team sport where folks from different disciplines work together to achieve a common goal. So looking at a working definition of the multidisciplinary care for healthcare management. And if you would indulge me, I'd use the acronym MHM. It is the coordination of the care of a patient or a group of patients by engaging professionals in their individual fields using multiple models for the collective good of the patient or the patients. And really, that's really just a long-winded way of saying teamwork is what multidisciplinary healthcare management is. It is integration of several models by numerous professionals to manage the healthcare need of a community. And a model is basically a framework, a tool, resources that are structured to help guide your intended goal. And so we'll talk about some of the models that are used by different disciplines within healthcare. A few keywords that are related to the concept of the multidisciplinary healthcare management include population health, systems of care, and care coordination. And if you're somewhat familiar with folks that work in a hospital, a case manager might be a good point of contact, might be a good point guard as well when it comes to the care of a patient or a collection of patients from a multidisciplinary approach. The MHM is focused on management, however, as opposed to maybe care coordination, like I'd mentioned, a social worker or case manager. But the MHM concept is focused on management. And so really looking at, the care of a patient from the vantage of a healthcare leader, someone who's intentional about management as their primary mode of operations. MHM reaches beyond the hospital, however, and into the community. And we'll spend a little bit of time talking about how the community comes into play. Now, the socio-ecological model in public health is one that I am a huge fan of. It's a model, it's a multi-level framework that really public health practitioners use to determine engagement and intervention at different levels of change as desired for the patients or the community in which they serve. And one way I like to describe this model is thinking of an onion and how it has several layers. And the innermost layer of that onion is the individual. And the individual level is, as you see, it's knowledge, it's attitudes, it's skills, it's that intrapersonal level of engagement. I'll move on to the next slide where we spend a little bit of time on each one of these levels. And so the intrapersonal focuses on the individual level action. So if say you were to help a group of people who were tobacco smokers, they've smoked for the typical 3-pack a day for the past 20 years, and say you've got 100 folks in this group that you intend to help. At the intrapersonal level, that's the individual level, you're addressing their beliefs, their attitude, their self-efficacy. And self-efficacy is public health word for, maybe personal belief in one's ability to change, to act in a favorable manner. And so at the intrapersonal level, what a public health practitioner would do is they would go and find ways to encourage that individual to be inspired to change. It has things to do with self-confidence. Locus of control is how I feel about myself, how I feel I can take charge of a situation. The interpersonal is multi-level, and that's my relationship with other folks. And that's when you think of folks who are married, research shows that folks who have partners live longer and are healthier in general. And so the interpersonal level at the socio-ecological model believes that if you can address things at that level, in other words, if you can encourage folks to have partners or to have accountability partners, if you were to go into that mindset, if you can encourage folks to work with others, at least one other person, the desired behavior of quitting to smoke, of tobacco cessation, could be achieved. The organizational level is concerned with guidelines and policies within an organization that encourages behavior. So for example, if the school UD decides that there is no smoking on campus, that's an organizational level intervention. That's an organizational level action in order to minimize the desire or the chances of each individual from smoking tobacco. On the community level, it really builds on the organizational. And so that's kind of like the, the city of Irvine decides that there will not be tobacco smoking in certain environments, maybe in the restaurants or whatnot. Those are community level interventions at that point. And so you could see that onion progressively get layered on. You start from the inside with the intra, the inter, the organizational, the community, and then the fifth level is the policy level. And that focuses on creating regulations and in essence, policies that will impact how folks live their lives on a daily basis. In order to achieve that policy level, governance comes in. You have to take it to your elected officials and the likes, depending on what district and what area you're in. An example, again, keeping the example of tobacco cessation, will be to basically require identification in order to purchase tobacco, or to if one were to add taxes to tobacco cessation, to the purchase of tobacco, that would also be a policy level. So the big picture from a socio-ecological model in public health, as we connect that dot to healthcare, to multidisciplinary healthcare management, is that the socio-ecological model encourages you to address not only the individual healthcare need of the patient in the bed or the patient in the outpatient setting, but it also encourages you to look at the holistic approach to that individual's life, connecting the dots to their relationships, to their organizations that they belong to the community in which they live, and how the external factor of policy level plays a key part on the individual health. All right, so chronic disease management. This is another sub as we kind of just get to a working definition of the MHM, the multidisciplinary healthcare management. I'll share here 3 different models that really fall into chronic disease management. And chronic disease management is in essence caring for patients that have a longer term prognosis when it comes to their health. In other words, you think of chronic diseases as COPD, which is the chronic obstructive pulmonary disease. You think of congestive heart failure. You think of diabetes. You think of the diseases that are not acute. In essence, you're not in the hospital for a flu and you go home. It's not a cold and you take a couple of meds and you feel better. It's an ongoing situation. And one of the things that we talk about in healthcare about chronic diseases is the multi-factor to it. In essence, comorbidities, and typically when you have one of these chronic diseases, the tendency to lay on to other chronic diseases is much high. It's behavioral factors that lead to them. And so chronic disease management is big picture as well. The AIMS model is the ambulatory integration of the medical and social model. Now, this model is intended to connect patients in the community health setting with non-medical supports and services to encourage intrapersonal care while addressing healthcare utilization issues. And so basically that's a fancy way of saying connecting the patients outside of the hospital to the help that they may need in the community that are non-medical, i.e. social worker, i.e. Identifying maybe a dietitian in the community. So the AIMS model of chronic disease management is getting folks outside of the hospital to connect to non-medical support. The chronic care model, which is the second one I share here, the approach is focused on patient care based on the application of interventions at different levels. As you can see, this is somewhat similar to the socio-ecological model we saw in the previous slide. And so the CC model here, the patient is one level that is engaged. The provider, and the word provider is used synonymously with physician and other practitioners, including nurse practitioners and PAs and mid-levels and psychologists and psychiatrists and the likes in the healthcare system. And so the idea of the chronic care model is to address the care of that patient at the patient level, at the provider level, so the physician or the medical personnel that has the expertise to meet their need, and then at the healthcare system level. And the healthcare system is synonymous to your hospital or collection of hospitals. The third model that I want to share here when it comes to chronic disease management is the community-based care transition program, the community-based care transition program. And this was developed by Center for Medicare and Medicaid Services, and it was to improve the transition from inpatient acute care to other care settings. So the transition is the key word here that the CCTP aims to achieve. Focus is improving quality care, reducing readmission for high-risk beneficiaries, and quantifying cost savings. All right, I'll break those three things down. Quality care. Quality care is, in essence, the highest care you can receive for the resources within your purview. The highest care that you could receive for the resources within your purview. Now, the second phrase there is reducing readmission. What's readmission? When a patient is discharged from a hospital, readmission is, in essence, when they come back for the same diagnoses or similar diagnosis as a result of possibly the initial care provided in the hospital was not sufficient to keep them outside of the hospital. So a patient shows up for, let's use the same example of maybe COPD, chronic obstructive pulmonary disease. They show up in the emergency room. Respiratory therapist like myself gives them a breathing treatment. Instead of being admitted to have the patient take maybe 3-4 days of breathing treatments, giving them not only a bronchodilator, but a mucolytic, maybe also giving them steroids. Those are the typical medications that are given. The ED, the emergency physician, decides to discharge this patient, right? And so they watch him for 24 hours, give or take, and they send him home. If that patient returns, and the CMS has specific guidelines, 30, 60, 90, if that patient returns to the hospital within a set time, that is a readmission that hits unfavorably to that hospital. It's an unfavorable admission as a result of possible misguided care on the initial visit. And so the last phrase there is quantifying cost savings. And that's where you connect the dots here from a business standpoint. Again, keep it in mind, we're talking about the multidisciplinary healthcare management. And when you think management, there's always costs associated, right? And so if a patient were truly transitioned from the inpatient to an outpatient, if in essence, if a patient was discharged after the care they received was appropriate, that patient should not return if they received, one, quality care the right way. That patient should not be readmitted if they received quality care, and the cost of that patient's care should not increase by that diagnosis. The cost will increase if they came back for the same diagnoses. So these three models, the AIMS, the CC model, or the chronic care model, and the community-based care transition program, are all models that touch on how healthcare really looks beyond just the hospital, how healthcare looks beyond the hospital. If you recall our previous slide, we looked at the socio-ecological model, looking at all the different levels of the community, organizational, and policy level. And these three models focus more on chronic disease, how healthcare reaches beyond just the hospital. All right, so I want to talk about management models, right? And one of the things that I'm fortunate to have done is gone through Lean Six Sigma training. I am a green belt, and if you are into karate or any of the other martial arts, There you typically earn your white, yellow. Well, you start at a white and then yellow and green and then on to a black belt. I've not attained the level of a black belt, but a Lean Six Sigma is one of the tools that healthcare leaders use. It is not exclusive to healthcare. It was actually in the automotive industry originally, and morphed into the healthcare industry over the last 20 or so years. Lean Six Sigma, basically the goal is to remove waste and to reduce variation to improve efficiency in a defined system. It is removal of waste and reduction of variation to improve efficiency in a defined system. Now, the system we speak of is healthcare. Now, if you were to narrow it down to a hospital, for a specific hospital, the use of Lean Six Sigma is to find where there is waste. Now, if we go to the previous slide and we talk about the chronic disease management, we talk about patients who are discharged but then readmitted. Now, that is a waste of resource if that patient is readmitted as a result of not being cared for in the first time. That is a waste situation. Now, it is believed that if you standardize a process and every step of the way is understood, it's articulated, is documented, I's dotted, T's crossed, that if you standardize that process, that there is a greater chance of efficiency. In essence, it's repetitive, but it's efficient. And so the goal of Lean Six Sigma, and it's basically variation from the standard deviation. And if you were to get to a technical statistics standpoint, basically it's reduction of the variation to improve efficiency in a defined system. All right, great question. Which model is the most common to manage chronic disease and why? I love that question. You know, and it all depends, John. John, I appreciate that question. It depends on what disease you're looking at. The example I gave you with tobacco cessation, if I were to go back a couple slides back, the socio-ecological model. In addition to socio-ecological model in public health, you have several other models. You have the stages of change model. You have cognitive theories. You have social support models. There are different models that are used, and research shows which is most aligned to a specific disease. And so it's somewhat disease specific, and tobacco cessation seems to align with the socio-ecological model from a public health standpoint. Now, from if I were using that same example on a chronic disease standpoint, I would lean more on the community-based care transition program. And the key thing with the community, and that was the example I use here with COPD, at the risk of keeping that as the consistent theme here, the CCTP specifically for COPD, and here's why. A patient that's discharged from a hospital for COPD is intended to follow up with their physician with prescriptions to the pharmacy and provided maintenance drugs, and maintenance drugs are of the long-acting bronchodilators. And so that model ensures that there's continuity of care around the specific need of that patient for that short period of time. It's kind of like a chaser. You need a chaser when you're given a bronchodilator in the hospital. That chaser is the long term. And so congestive heart failure would have a different model that's more aligned. But yeah, it's a great question to ask which model mostly aligns with chronic disease. My cliff note answer would be it's disease specific. Now, we talked about Lean Six Sigma a little, and just looking at the other two models from a management standpoint, DMAIC, and DMAIC focus on the quality care aspect of healthcare management. And the acronym is design, measure, analyze, improve, and control. Those are the tentacles that go with DMAIC, DMAIC, DMAC, depends on how you want to say it. But it's a tool that healthcare managers, healthcare leaders, healthcare administrators use in order to improve quality care. It is focused especially around quality care. One of the things that I value in my colleagues that are healthcare leaders as well are those who maybe they didn't have the opportunity to be clinicians, but they've gone and done certificate courses around quality. Quality is integral to healthcare in general. Quality is the bedrock, if I may say, clinical quality care is the bedrock of healthcare leadership and management. And so DMAIC is a great tool that folks who go that route learn specifically. And what you do is you design a program, you measure it, you obviously analyze it to ensure that it's meeting the needs. You improve on it from what your implementation is, and then you control for any confounding or other variables that are unassumed at the time of the implementation. All right, so the third management model that I want to touch on here is the 7S change model. Now, this is a McKinsey model. McKinsey is a consultant firm that they've done an amazing job, and this model is well over 20 years at this time. They've done an amazing job really in the healthcare industry. I'll share with you that McKinsey was at one point the consultant company for two of the largest healthcare systems in America, two of them being the American corporations, the Hospital Corporation of America, HCA. I worked for HCA for 12 years. And then Tenet was the second largest, or still is the second largest, which is the company I work for. McKinsey has consulted for both large companies. They've done an amazing job for healthcare. And so the 7 components of McKinsey's model are strategy, structure, system, style, staff, skills, and shared value. And the idea behind this is if you were to try to improve healthcare, if you're a healthcare leader that gets the responsibility of a CEO for a healthcare system, you want to have a strategy in place. You want to put structure to your strategy. You want to have systems that support that. And your style is your leadership style that really works for you. From a staff standpoint, it's important to value your employees because they are the foot soldiers that make sure that care is provided. They're the biggest factor to the patient engagement, in essence, patient satisfaction. The phrase used in healthcare today is patient engagement. And then skills, that's the skills that are needed to understand healthcare, and then shared values as well. Shared values are basically the culture of the model of the community or the healthcare system in which you are now responsible for. So these 3 management models are tools that are used from a healthcare management standpoint. Let me pause and see if we have any questions at this time.
I have a list of some questions that students had submitted, but I'll wait until the end because they're sort of, it's sort of a general overview. Yeah.
Great. All right, so members of the healthcare team, and this is, I was intentional to put as many of these folks as I could remember. Now, it's an exhaustive list. In essence, there are many more folks who participate in healthcare in general. Physicians are the ones that many of us, we know quite often. The nurses, we know who are nurses. Therapists, as I'd mentioned, I'm a respiratory therapist, but in addition, there are physical therapists, there are occupational therapists, there are respiratory therapists, there are speech therapists. In addition, that you have social workers who I alluded to when it comes to chronic disease management, and case managers as well. You also have imaging services. And what I want to touch on here is when you speak of imaging services, it includes radiation technologists, it includes MRI, which is magnetic resonance imaging technologists. It includes nuclear technologists. There's several folks who are trained CT, which is computerized tomography. In essence, ways in which you can view the body, all inclusive within the imaging services. Imaging services allow the healthcare system, allow your physician and other who are interested in the patient's care, it allows them to see what's going on the inside. It basically gives you a picture of what the patient's is going through. The EMT are folks who are certainly a part of the care team. They are actively involved in more so the pre-admission to the hospital, and in some cases in the emergency room. And we've seen the role of the EMT really grown lately. A lot of EMT folks are now part of community care, community health. there are several programs in different hospitals and cities who now have EMTs going to follow up with that said COPD patient we've discussed, with that said diabetes patient. In essence, they're working as community health workers, and because they're quite very knowledgeable. Your EMT is able to do a lot of things. They can give medications, obviously in the ambulance. They can intubate, in essence, put a breathing tube down the trachea of an individual who needs respiratory support. They can obviously perform CPR and the likes, and they are educated as regards medications, classification. So we've seen the role of the EMT really grown most recently in current and recent trends. Laboratory services is another group that's actively involved in the care of folks. You have your medical lab scientists, you have your medical lab technologists as well, varying degrees of education. But in essence, being able to identify the pathology of a patient based on the blood work is where our laboratory partners really are helpful to the healthcare system. At the risk of leaving it just clinical, I've included a few others who are not clinical. The registrar. Healthcare continues to be a business, and the role of the registrar is to ensure that the information received from that patient is in line with their identity in the community, and so the driver's license and the like. So right, just as you all have registrars in the school system, the registrar is one to enroll that patient through the electronic medical record, also for documentation purposes for the care that they will receive in the hospital, as well as on the outpatient standpoint. Financial services, revenue integrity, I put this in parentheses. And what revenue integrity is, the role of a revenue integrity director or director of revenue analysis, depends on where you see it, is one who ensures that every care provided to that patient is billed, not $1 more, not $1 less. In essence, if the patient arrives and the need is for a patient shows up for stroke or whatnot, the DRA, the Director of Revenue Analysis, or the Revenue Integrity Director, is responsible for looking at the DRGs, which are diagnosis-related groups, and DRGs are how healthcare systems and insurance companies communicate with one another on what they did and how much they get paid. Basically, that's what a DRG is. The hospital system uses this tool to communicate with the insurance company on here's what we did for this patient, and therefore the insurance says this is how much we're going to pay you for that care. So the role of the revenue integrity of the DRA is to ensure that those two things match up, that this patient arrived for stroke and we did not bill them for anything more and nothing less. And there are several DRGs that are used. And so coding and billing all roll under the revenue integrity team. And obviously your financial officers are active members of this finance services. The environmental services, and we've seen trends in healthcare where the environmental services are really now being rolled into the infection disease and infection prevention departments. And in essence, the environmental services are folks who, keep the floors clean, make sure that the rooms in the patient's room are well attended to, the bathrooms, the common area. The janitors are members within the environmental services. But we've quickly realized that the role of the environmental services worker is a heightened role within healthcare. If you were to swab your phone for bacteria and fungi and some of the other things that are maybe unfavorable, one might find a lot of things on that. And likewise, transparently, a hospital. And so the trend is to really hold the EVS, the environmental services team, to work closely with the infection prevention folks so that they have a heightened view of keeping the environment clean for all our patients and all the caregivers that work there. Facilities management, a lot of hospitals are run under or on top, I should say, a lot of old equipments, and that includes your HVAC system, your air ventilations, and also a pneumatic tube. Think of sixth floor hospital, patients on the sixth floor, and the lab is on the second floor. You ask yourself, how does the nurse on the sixth floor get that blood work to the lab? Do they, every time they have to draw blood, do they walk down to the second floor? Do they take the elevator? No, they don't. They put it in a tube, a pneumatic tube that's, you know, connected through the entire hospital, and it's transported to the lab, wherever the lab may be. And so the running and the operations of a hospital is, from a facilities management standpoint, really goes beyond the typical HVAC. It goes into a lot of, and that's just one example of tools within the hospital, within the healthcare system, that are specific, that a facilities management team supports. Food and nutrition, certainly. Food is a fuel for life. And so having a dietitian and the likes be a part of your healthcare team is truly important. Pastoral care, and I think what you'll see from a trend standpoint is it's that term pastoral care is morphing more into spiritual care, to be all inclusive of all sorts of faith. And so pastoral care basically addresses the spiritual aspect of health in general. And of course, you've got psychologists, therapists, counselor, and then management staff. And the role of the management staff is really just to make sure that everything we just discussed is moving in a well-oiled machine. All right, so here are just a couple new trends that I wanted to share with you all. Vizient is a consultant company, and here's what they define as service line management. Service line management, which is my current role as a service line administrator, is defined as patient-centered care related to a specific area of clinically related conditions or procedures integrated across a system of care through strategies, insight, process, and people. And so basically that's a fancy way of saying that service line involves, usually it's one specific disease or DRG diagnosis that then care is surrounded. And the role of a service line administrator is be that point guard, be that high level project manager that ensures that the workflow of a patient from admission to discharge and even beyond discharge in the hospital is met. Everything that patient needs pre, during, and post care is supported by the service line administrator. Nasr Abad, from his article, point out that there are 4 managers' competencies that are important for a service line leader: conceptual, collaborative, interpersonal, and leadership competency. These are 4 things that are important that he believes that a service line manager or service line leader should have. And I think they're the most important, if you ask me, is to be collaborative. As a responsibility of a service line leader, you often do not have any direct reports. In essence, you don't have anyone that you can wield your authority on as a result of, I pay your bills, but you lead their influence. And so in most cases, you have to be truly collaborative and truly able to work across several lines in order to achieve the common goal. Miskell in 2021 speaks about improving patient experience as an integral part of service line. It reduces system out-migration, it enhances accountability, and it aligns providers clinically and financially, and also controls costs. So in essence, the role of a service line leader in healthcare management is one who ensures that the patient is cared for, that patients that come into your system do not go elsewhere. That's what we describe as out-migration. Patient that arrives in your system that goes elsewhere has out-migrated from your care. Now, again, keep in mind, healthcare systems are in most cases there from a business standpoint. And so we do not want to lose our patients. We want to certainly meet their needs wherever they are. A mother who just had a baby has that baby in the hospital, goes home the next day, but that baby is going to need some shots. That mom's going to need follow-up care with her, with the OBGYN, and that OBGYN is likely employed by my healthcare system. And if she has any lab draws that's needed, that lab draw is done in my outpatient lab. That lab is ran and read by a pathologist that is employed by my system. The goal is to be there for our patients, even when they're not in the hospital. That is what a service line leader does. We care for the collective need of that patient. I give a couple examples of service lines. as I mentioned, women's and children, cardiovascular service line, neurosciences, bariatric, orthopedic, behavioral health, and oncology. All right, I got a couple more slides and I'll pause for questions. Dr. Toby, if it's okay with you, you're welcome to share these slides. I have hyperlink that speaks to a few of these things. And service lines put the patient first is what a great article from Johns Hopkins speaks to. And I just wanted to share that because it's important to remember that the role of a service line leader is one who keeps the patient as the core of the care that's provided, but brings everyone together collectively to achieve that. It brings the administrators, at the hospital level, brings the clinicians, brings the clinical folks within the hospital, as well as those in the outpatient. There's a great webinar that I think was worthwhile watching. It's on demand, so you can watch it after the fact. Market transformation through hospital musculoskeletal service line optimization. And really just, you could replace musculoskeletal with women's or whatnot, but it talks about how to basically transform the environment, the community in which you serve through optimizing your service line, through making sure that your service line is well run. Healthcare service lines and the state of the future is a great one that also speaks to new trends in healthcare. And Lumina Health shares 4 pillars of clinical service line success. And I thought I'll share that. One of those pillars is governance and leadership. And so your service line leader must be able to really work closely with leadership at all levels. You've got service definitions. So in essence, you define that service line. Say, for example, let's use oncology as a service line we use here. Dyad administrative model. A dyad administrative model is where the administrator works closely with the clinician leadership. So I'm the service line administrator for neuroscience, but I actually have a medical director from my neuroscience service line who's my colleague. So that's the dyad administrative model. He's a physician, I'm not, but we work collectively. I lead the system from that standpoint of administration and operations and strategy and service line. He leads it clinically. And of course, physician leadership is important, structure and participation. When you look at the second pillar, clinical integration, basically access to care is how we provide care to the communities outside of our primary service area. In a healthcare system, we think of our purview as primary service area, secondary and tertiary service area. And so we are intentional about providing access not only to those within our primary, but those in the rural areas or outside of the bigger community. Managing the leak is a responsibility that the service line leader has. He or she is also responsible for contracting, network management, and the likes. Clinical transformation is the third pillar, and it speaks to basically the evidence-based medicine. And so it's truly important that your service line leader have science as their background, understand as much as possible of ways in which what's clinically proven could be transcribed and translated into the real world. Your care model redesign, in essence, being able to modify models that are not necessarily cookie cutter, take what's already established elsewhere and fine tune it to your community. The service line leader must be able to do that. Cost and quality goes without saying, and care coordination, as we've spoken of extensively. Now, analytics and innovation is also important when it comes to service line leadership. KPI is basically a key performance indication that we as service line leaders track. If you don't measure it, it didn't happen. And so we use KPIs to assess how well we move the needle on our goal. I'll give you an example. Door to needle time is basically how long it took us to get a patient from coming into our ER into the neuro lab in order for them to, or door to groin specifically, in order for the interventionist to care for them. Brain is time and time is brain, so time is important. We measure that as a KPI. And then of course, performance-driven care, artificial intelligence, that's what AI is. We use artificial intelligence in the healthcare industry. The role of the service line leader with that is to make sure that it meets the needs of the community, as well as manages the resources to acquire those up and coming technology. All right, and these are just some resources or references that I think would be helpful for anyone that has questions about my presentation. I think the high view I wanted to give you all as healthcare, from a multidisciplinary healthcare management standpoint, is that healthcare, it takes several people to achieve the goal of caring for our communities, caring for the individual, and caring for the system. Thank you. Dr. Toby?
Thank you. Thank you. If we could give a virtual clap to Dr. Bamiro for that. Wonderful overview. Again, focusing on healthcare management and healthcare management in teams. So I know there were some pre-submitted questions. I was just going to ask you a few of those, but I certainly want to allow the students. I know several of you sometimes are sharing the same screen, but if you could chat your questions directly, that would also be great. So I'm just going to throw a first question, and then we'll see if there are any chats that come up. So one question is, in terms of skills. So, the students are acquiring several different types of skills, and then they're going to go on to professional school. You've had, a career trajectory that really covers a lot of different areas. So you've worked both as a healthcare provider, but then also on the management side. So what are some specific skills that you think have helped you in sort of the transitions from being a student to being a working professional? And so in terms of at this juncture that the students find themselves in, are there additional skills that you would suggest? So if you could comment on specific skills you feel had helped you back then, or if there were things that you hadn't known, but you started working and later acquired them. So if you could comment on those.
Absolutely. Thank you so much for that question. I'll share two. One is networking. That's one that it took me a while to understand the importance of that. I come from a background where I believe my work, my skill, my ability to deliver care to the patients and deliver on the skills I've learned should help move me further. And it has. Having said that, the ability to also network with others and to, in some cases, know when there's an opportunity to move up has been very helpful. I think the other one that I would say is, and it kind of builds on networking, is finding a mentor, finding someone, and I wouldn't call it a skill, but I think it's important from a career trajectory standpoint. If you can identify an individual who has walked the walk, the path in which you so desire, and you can invest in a relationship with them, they would probably shorten your time to get to that destination. They would shorten your time in getting there. So I think networking and working closely with a mentor would be my advice.
Okay, great. Thank you for that. Questions in the chat? I don't see any questions in the chat, but again, feel free to unmute yourselves and ask as well. The floor is open.
I have a question.
Yeah.
I'm curious. Well, first, thank you for this talk. I thought it was really interesting and really informative. And I guess I'm wondering, just both in the transition from patient care provider to administration, but then just also just in general in the administrative work, what have you found to be some of the biggest challenges that you face, especially working with so many different people and coming from so many different perspectives? What do you find to be some of those, I don't know, I want to say obstacles, but just differences?
No, I think that's a great question. I think one of the latter points I made was, in some cases, especially the role I'm in right now, your authority is, or your leadership is by influence. And so one of the challenges that often happens even when you have direct reports. Say you're a chief financial officer and you're responsible for the financial wellness of the company. There are nurses and other disciplines who are not directly under your reporting structure. And in some cases, that could be an obstacle, that could be a barrier. You have your goals, but your goals may not be theirs. I'll give a specific example. With COVID, we've had a greater need for clinicians. And so as a result of that, our nursing leaders, in order to be competitive, want to pay nurses and techs a lot more. A CFO does not want to do that. A CFO is incentivized to reduce costs. And so having that competing priority and learning how to manage that is both an art to it, but it could be an obstacle as well.
Great, thanks for that question, Dr. Pesia. Additional questions from any of the students? There was another pre-submitted question I had about, so from your bachelor's study before you started grad school, did you take a gap year? If so, what did you do during that gap year? If you could comment on that. We have some seniors and some rising seniors on the line and thinking about, the potential positives or pros and cons to taking a gap year, and what to do with that gap year, I think is a big question.
Yeah, I think the approach is to know yourself. I knew that if I had taken a gap year, I probably wouldn't have gone back to college. So I chose to continue, and it was expensive, right? Because in an attempt to continue not knowing exactly where I wanted to go to, here's what I didn't share. After my bachelor's and moving to Oklahoma, thinking I wanted to go to pharmacy school, I chose to pledge in a fraternity, and I had one semester that was not the nicest grades, which was a semester when I pledged my fraternity. I got a D in biochemistry, yeah, I know that's bad, and it was only because I pledged. It was clearly because I was preoccupied as a 21-year-old. But I chose to continue because I knew that if I paused, I probably would have just caught on with other things. I don't think it's a bad idea to take a gap year if you are disciplined enough to pursue what it is that you still want to at a later stage. But if you're the individual like myself who a gap year means I'm not going back to school, then maybe reconsider that.
Okay, great.
Say thank you.
Go ahead.
No, I just want to say thank you for sharing that. I think sometimes so many of our students get really hung up on, always having to make A's and everything. And sure, that's important. But I like hearing these stories that say, hey, you can still be successful and have that one semester that doesn't go perfectly. So thank you.
I did graduate with a 3.9, but it was just something. Here's what it was. It was that class was when I had to take all the activities that had to do with my fraternity. And so there was no way I was going to get it done.
Yeah, thanks for sharing that. I agree with Dr. Pesia. It's always good to hear from someone that's sort of been through the hurdles or challenges and has overcome it. And I think it's also, so students shouldn't be too hard on themselves and just know that it'll all work itself out at the end of the day. So it's a very good lesson and good reflection point, I think. So we're at the 7 o'clock mark, so I want to be respectful of everyone's time, but I do want to make sure I didn't miss any chatted questions. For those students on, if you can just chat directly to me, I'm going to go ahead and do the number draw for the Starbucks gift card. So if you can chat directly to me, so that way I'll know to include you in the draw so that I don't miss anybody. And again, we do want to just say a big thank you to Dr. Bamiro for this evening. It's been a delightful presentation, and this is also recorded, so we'll be able to share it. And I think that is awesome. Okay, I've seen, okay, I can see the chat to me. Great, great. So with my random number draw here, just generating a random draw. So it looks like we have our winners. And I'm going to relate that back to you all. So you all should be getting an email from me, and you all will be able to access that gift card. So again, thanks for joining. And any closing thoughts from you, Dr. Pezia?
No, just thank you. This was a really wonderful evening with lots of information. I think next time we need to think about getting the Office of Professional and Career or Personal and Career Development, because I feel like this would have been a great talk to hear for so many of the business students to hear as well, just because you do bring in so many different perspectives and they're important for all our students to hear, because especially some of the ones who like know that they want to work in something that is management related or administratively related, but they haven't thought about healthcare. And there's clearly so much that they can do, and it's such important work. So thank you for sharing your time with us today.
Yeah, and
Thanks for having me.
I echo what Dr. Pezia said. Certainly outside of the biology department, I think the business students would really, really benefit from this as well, just because they tend to, the biology students are, they're on the healthcare side or public health in some capacity there. The business students may not necessarily have that lens. And so I think it would be really worthwhile. And I'll actually reach out to them and also share this this clip with them. But I do think it would be great to have you back to have that audience also, gain from this information that you've been giving us today. So I think it's wonderful. So again,
here. Love teaching. So happy to.
Awesome. So again, I'll virtual UD clap for Dr. Bamiro, and wish everyone a wonderful evening and also a wonderful Easter break coming up. And until we see next time, thank you so much, Dr. Bamiro, and have a wonderful evening too.
Thank you all.
Thank you.
Bye.
Thanks.